everyone. Welcome to the Preemie Chats, and thank you so much for joining us here today. I'm Fabiana Bacchini, Executive Director of the Canadian Premature Babies Foundation, as known as CPBF. We are a charitable organization, and our mission is to empower families of premature babies through support and education. This Preemie Chat series is one of the many initiatives we have to bring information for NICU families and healthcare professionals. Here, every Friday, we talk with experts, researchers, and parents who share with us their knowledge and experience. Also on our website, canadianpreemies.org, parents will find all kinds of resources and support. And today we are going to talk about simple solutions for saving lives, neonatology options in low resource settings. Caring for premature babies in the developing world presents a unique set of challenges. How can we circumnavigate limited resources in order to provide evidence-based quality neonatology care and save lives? This talk will focus on using homemade bubble CPAP machines to treat neonatal respiratory distress, kangaroo care for thermoregulation, filtered sunlight and homemade phototherapy machines for jaundice, breast milk cream to provide improved caloric intake for low birth weight infants, and the importance of early recognition and treatment of infections in newborns. And I'm so honored to have here Dr. Sarah Hudgins joining us live for Cape Breton, Nova Scotia. Dr. Hudgins is an associate professor of medicine at Dalhousie University. She has long been interested in international medicine and completed several short-term trips to Bangladesh, Mexico, Haiti, and Angola before moving to Angola in 2015 to work with the Samaritan Spurs. Child mortality rates in Angola were appallingly high at the time, with 20% of children dying by the age of 5 and 10% of children dying within the first week of life. Dr. Hudgins returned to Canada in 2017. She spent several months retraining in a neonatal intensive care unit in Regina and networked with pediatricians around the world to try to compile ways of keeping babies alive in a low-resource setting, such as Angola. Dr. Hudgins, just reading your work gave me goosebumps. Honestly, it's so incredible to see what you have done and the incredible ideas that you had and worked on. So welcome to our Preemie Chat today.
Thanks very much for having me. It's truly an honor to be here. I don't think I started off my career expecting to be a neonatologist. I trained as an OBGYN. I always loved babies, but when I landed in Angola and realized that 10% of newborns die within the first week of life, it truly did not make sense to me to try to provide quality maternity care without also working towards improving neonatal care in that sense. So that's why you're talking to a gynecologist today about simple solutions for saving lives, neonatology options in low resource settings. So here we go.
Dr. Hudgins, I will let you control your slides. And for all of you watching us live today, please do send your questions, your insights, share with us your experiences. Dr. Hudgins is going to address them at the end of her presentation. Thank you.
So I moved to Angola in 2015. My first trip was actually in 2014 when I encountered some of these abysmal statistics. At the time that I was there, Angola had the worst under 5 child mortality rate in the world, mostly due to premature birth, lack of basic obstetrical and newborn care, and infections. So it was in 2014 when I came back that I redid some neonatology training to try to get some extra skills to figure out what to do in this context. The leading causes of death in newborns worldwide are recognized to be related to prematurity, birth asphyxia and trauma, infections, and birth defects. So very common to what we were seeing in Angola. 75% of newborn deaths worldwide happen during the first week of life, and 45% of those deaths happen within the first 24 hours. This is one of the most updated charts looking at, numerically speaking, which countries have the highest number of newborn deaths in the world. These statistics are a little bit different than the ones that I was working with. Angola has actually improved its neonatal mortality rate, but you can see that there are a lot of countries in the world where this is still a major issue. The WHO came out with several sets of recommendations about how to reduce morbidity and mortality of preterm infants in low and middle income countries. And when I started looking through that list, I was trying to figure out what is actually realistically doable in a low resource setting. They talk about antenatal steroids, tocolytics for preterm labor, magnesium sulfate for fetal neuroprotection in preterm births, and antibiotics for preterm labor. Those all seemed reasonably manageable. Sometimes there were medication shortages. Antenatal steroids were not always well known in areas where I worked, but we had access to them. They were pretty straightforward in terms of implementing. But the rest of the WHO recommendations were a little bit harder. They talked about kangaroo care, which is very accessible, but simply just was not well known in the areas where I was working. And we'll come back to that a little bit later on. CPAP machines, surfactant, and oxygen concentration was kind of like, what's that? Like that just was so far beyond the reality of what we were working with. That I wasn't sure we could really do much about that, but I thought at least we'd start looking into it. So when we sat down and did some research and networked with pediatricians working literally around the world to try to come up with the solutions, these are the 5 areas that we decided we would focus on. CPAP for respiratory distress, kangaroo care, hand expression of breast milk cream, otherwise known as hind milk, for low birth weight babies, different phototherapy options for jaundice, and then focusing on managing and treating infections in newborns. So let's go through those one by one. Number 1, you can actually make a homemade bubble CPAP machine. I first saw this in rural Bangladesh and was actually quite surprised to find that there is actual research looking into it. This is an excellent article that came out by Trevor Duke in 2014, and it goes through it step by step. How do you literally build a homemade bubble CPAP machine? You need nasal oxygen cannula, you need oxygen itself, tape, ruler, a pair of scissors, and a bottle of clean water with a lid and 2 holes in it, and that's it. You can see in the picture there an image of one of our setups in Angola. Neonatal-sized nasal cannula were not always accessible. You can use adult-sized nasal cannula. And in some cases, adult-sized nasal cannula might be better because you do need quite a good seal around the nostril. And if there is not a good seal, one of the tips that I learned was to take earplugs, cut a little circle off of the earplug, and stick it around the nasal prong in the nose just to provide a better seal. The statistics show that it actually works. Homemade bubble CPAP machines result in a 66% reduction in in-hospital mortality rate following CPAP use in preterm neonates, and a 30 to 50% reduction in the need for mechanical ventilation when bubble CPAP was used. One of the hospitals that was helping me strategize how to make things work was the Kijabi Hospital in Kenya. And at the time that I was there working in Angola, Kijabi Hospital had some of the best neonatal survival rates in all of Africa, down to 28 weeks gestational age, only using CPAP. They did not have mechanical ventilation at the time. There are also some interesting studies looking at homemade bubble CPAP machines, even in older children and infants, so not just preterm infants, and there is evidence of success and benefit in those cases as well. There is a focus on trying to not overdose premature babies with high concentrations of oxygen. And managing oxygen concentration was something that we weren't always able to do well. But again, something is better than nothing. And so that was the focus that we were going with. The other thing we found is that there were community groups that wanted to get involved in Canada. And so we had a couple of community groups who started knitting hats specifically for our premature babies needing bubble CPAP. They have the little Velcro on the side because we had limited access to tape. And the tape that we had access to tended to tear the skin on the face of the premature babies. So we were trying to minimize using it. And so we had these little Velcro strips. They would knit these hats for us. The next thing we looked at was kangaroo care. So wrapping up our little ones. What is kangaroo care? There is some variation in definitions depending on which sources you use. The Cochrane Review reports it as skin-to-skin contact between a mother and her newborn, frequent and exclusive breastfeeding, and early discharge from the hospital. Most studies show that the most important component of that is the skin-to-skin contact itself, and it does not have to be just the mother. Traditionally, it is the mother who provides this, but it can be any parent, guardian, or essentially any warm human being. This patient in the photo, she had twins. And so at times the grandmother actually would do skin to skin with one baby while the mother was feeding the other one. I actually did skin to skin myself once in a while in sheer desperation. If the mother was recovering from a C-section and there were different challenges with family members. So it can be done with whoever is available. There are significant benefits for preterm babies. Compared to typical newborn care, low birth weight infants with kangaroo care at discharge had less chance of dying, less chance of catching a hospital-acquired infection, less hypothermia, better breastfeeding rates. They actually had faster breastfeeding starts, improved sleep organization. They were more alert and less fussy. And they had improved bonding with parents who participated in the skin-to-skin care. There was a lot of controversy initially about should we be doing this for sick and unstable infants or just with stable newborn infants. And there is more and more evidence coming out that it can and should be done as soon as possible with all infants. Again, there's lots of studies out there that you can look at in terms of stable infants, not stable infants, but there are some studies even showing that unstable infants tend to do better in the long run with skin-to-skin care when possible and within reason. The next thing we looked at was nutrition. How do we optimize feeding for low birth weight babies? And the reason this was an issue for us is because formula feeding, which is usually the answer for low birth weight babies or babies with high nutritional needs here in Canada, they will get supplemental formula, high calorie formula in particular, or they'll have formula additives to breast milk, whatever. But that was simply not realistic, partly for cost reasons and largely for safety reasons. Formula fed babies in low and middle income countries have statistically significantly higher rates of dying. There are studies out there actually looking at what percentage of neonatal and infant mortality is directly related to marketing strategies by companies selling formula in the developing world. There's just one sample that I put up here. There are two challenges with formula use in low and middle income countries. Number one is that the water is almost always contaminated. And if the water's not contaminated, then there's improper sterilization of bottles and nipples. So infectious risks are very high. The second challenge that is very common is malnutrition. Parents are trying to cost save because formula is expensive. They dilute it down. And so babies were being admitted with malnutrition and starvation, in addition to diarrhea and infectious diseases because of all the complications surrounding formula. In fact, the WHO in many situations does actually not recommend formula feeding infants born to HIV positive mothers, just to put it in context, because your risk of dying as a newborn bottle-fed baby in a low and middle income country is higher from diarrhea than if you are breastfed by your HIV positive mother. That's just to kind of put it in perspective. So what we started doing, and this was based on some studies that Tina Slusher had published, is hand expression of breast milk and feeding the cream to the babies. What do I mean by that? Breast milk comes in two main components. Initially, the milk that comes out is called the foremilk. That's the white stuff on the left. On the right, you see the hind milk. That's the cream. Cream contains more calories, logically speaking. When you prioritize feeding hind milk first to the low birth weight infants, you optimize their weight gain. So the way this is done is the moms would express breast milk until the breast is just about empty. They need to change collection bottles when the milk starts to change color so that they can separate out that hind milk or the breast milk cream. And then the hind milk was fed first to the low birth weight infants, whether that be syringe feeding, gavage feeding, spoon feeding, whatever method you could use. What they found in their studies is that the infant weight gain was significantly higher when babies received the cream first compared to receiving just regular breast milk. And that was a difference of about 8 grams per day. They did find that electric breast pumps gave the highest volume of breast milk, but what they also found was that it actually wasn't necessary. The vast majority of mothers were able to successfully hand express enough breast milk to meet their baby's daily nutritional needs. The next thing we looked at is phototherapy. This is sort of a quote unquote traditional phototherapy in Africa, which means an almost naked baby in the sun with close monitoring of temperature and hydration. Tina Slusher writes in one of her research articles that severe neonatal jaundice with progression to kernicterus is probably the most under-recognized and underreported cause of preventable neonatal morbidity and mortality worldwide. There are multiple challenges in treating jaundice. Electricity is erratic and often unreliable in various places, and the technology for treating jaundice can be quite expensive as well. You've essentially got a couple of different options. Buying a phototherapy machine, you could try regular sunlight, but we know that there are risks of UV light exposure. And then you have the challenges of thermoregulating a naked infant who is outdoors, particularly year-round, depending on what time of year it is, or if it's raining or not, so it's a little unpredictable. You could try filtered sunlight or a homemade phototherapy machine. So we focused on the last two. Filtered sunlight means you take car window tinting film or something similar, and you use that over top of the baby to filter out some of the harmful UV rays, but still allow phototherapy treatment. Again, you still need frequent monitoring of baby's temperature and hydration. It does work best in countries near the equator, but one study has showed that it successfully treated jaundice in 92% of infants. So it certainly is a valid option to consider in these settings. And car window tinting film is pretty universal. It was relatively easy to find in the countries where I was working. The next option is that you can actually build your own. Hendrik J. Vreeman has put together, I've never met him myself, but I was given access to his template. You can build a homemade phototherapy machine. This is a picture of ours here. You can actually use white fluorescent lights, which are much more accessible and affordable in a lot of these countries. Blue fluorescent lights has better treatment rates with jaundice, but white is still a reasonable alternative. We also had a lot of knitters supporting in the area where I was, and they knit us some cute eye protection masks to go along with the phototherapy as well. The last thing we're going to talk about today is the importance of recognizing and treating infections early. Back to one of our earlier statistics, infections are one of the leading causes of death in newborns. there were a lot of challenges that we faced in treating newborns with infections. The supply chain, I mean, we complain about COVID-related supply chain issues. I feel like you have seen nothing if you have not worked in a pharmacy in the developing world trying to get access to medications regularly. Culture and sensitivity profiles may be completely unavailable or unreliable. In the area where I worked, the only microbiology lab was at the veterinary hospital, and they tended to test only antibiotics such as amikacin, which they use in cattle apparently, so it was not necessarily very helpful for us. Neonatal concentrations of medications are often widely unavailable or very expensive. Neonatal IV cannulas were hard to find, they were expensive. And we had lots of safety concerns about lack of nursing experience with managing neonatal IVs. The areas where I worked sometimes only had 500 ml or 1 liter bags of IV fluids. And there were actually cases in my area of neonatal deaths from pulmonary edema when the nurses left an IV running with a 1 liter bag up. So how did we manage some of that? We focused as much as possible on oral or intramuscular antibiotics and antimalarials where possible. We tried to establish double checking of the calculations when you're going to dilute down a medication, and we tried to develop fairly strict protocols about how to safely dilute antibiotics down to give them to a newborn. And we tried to steer clear of IV fluids entirely wherever possible. And if an infant absolutely needed IV fluids, we would do an IV push with a syringe and stay away from hanging IV fluid bags just to try and minimize some of those risks of fluid overload. So just to recap, you can actually make your own bubble CPAP machine. It is both affordable and functional. Kangaroo care is life-saving, and we should all be doing more of that. Skimming off the cream and prioritizing hind milk for low birth weight infants will significantly improve their weight gain. You can cobble together phototherapy options. And we talked about some tips and tricks for navigating neonatal antibiotics and antimalarials. And essentially, I guess the point that I wanted to bring up today is that much is possible when you ask for help and start thinking outside the box. A lot of this would not have been possible if I had not had tremendous help from pediatricians who were willing to work with me from around the world to try to figure out what options do we have available. I put up a bunch of resources here for you folks. I just wanted to highlight some of the courses from the American Academy of Pediatrics Global. They have got free downloadable information about essential care for every baby and essential care for small babies. It's free and it's translated into multiple languages, so very useful resource. Tina Slusher is one of the authors of several of the studies that I quoted today. She's based in Michigan, I believe. And Kijabi Hospital in Kenya also has some of those courses provided that I was mentioning. I know there's more resources out there, but that at least gives you a place to start. So thank you for your time today, folks. I am open to questions.
Dr. Hudgins, thank you so much. I'm just sharing your resources here. Give me 1 second. So I'm going to make all the links live on comments so people can actually see them there. Because it's very hard to follow a very long URL here. Here you go. All your resources are on comments and live links so people can actually see and click on them. But thank you so much for your presentation, for the work that you've done. It's truly remarkable. And I love the fact that you ask for help and think outside the box to come up with solutions. And I feel so privileged to have had my son in Canada with a completely different setting and resources. I'm from Brazil, and you're talking about this. I imagine some areas in Brazil, very remote areas, we face many of those challenges and for care and how to get supplies. And I think about all these people live in the middle of the Amazon. What do they do? So it is incredible. So my questions to you, I have a few questions. I think one, what are the challenges that you face when you go to those places and you come with your knowledge, it's okay, let's come up with solutions and pretty much change the way they do things. So what are the challenges that you faced, the resistance perhaps that you faced to implement some changes?
I think one of the most important things that I've learned is that you have to meet people where they are at. You can't come in as with an attitude of superiority, as though you are better and you have all the answers and you're going to fix it all. That will not go over well in a lot of settings. I have found it to be much more effective to approach people and say, what are some of the things that you recognize are the main challenges? What are some of the things that you have tried? What are some of the things that you would like to try? Because when you have them involved, your long-term success rates are much higher, because then they're excited about it. So for example, when I first went to Angola, we did not have bubble CPAP. Premature babies were dying. I found it really quite distressing, because I knew that those neonatal mortality rates were not necessary. There were things that we could do. The midwives didn't believe me. And I went back to Canada, I retrained, I learned how to make the homemade bubble CPAP. I came back, I showed them how to do it. And all of a sudden it started working, and the preterm babies started surviving. And the midwives themselves actually came to me and said, Doctora, it actually works. You weren't kidding us. And then they started using the bubble CPAP machine, even if I wasn't around. So I feel like when you have buy-in from people locally, it just makes such a more sustainable difference in that sense.
Yeah, so that was my question. Like, how do you sustain those changes? Do you train the local people? Do you work with them? Because
Yes.
I feel from everything that you said, there's a lot of education that needs to take place to
Absolutely.
implement and become sustainable. So they are the champions, right?
Yeah. So another challenge that we ran into is things like Helping Babies Breathe, which is an excellent course, was not available in Portuguese at the time. And so we actually did some fundraising and worked with some people to get it started to be translated into Portuguese. In the meantime, I had a binder that I was putting together where I was attempting to translate stuff myself. And Portuguese is my third language, so probably not excellent Portuguese, but it was at least enough with diagrams that they could learn to use it on their own. So that kind of a thing, education is just key.
So let's talk about kangaroo care, because there's a lot of conversation about kangaroo care. Yesterday was World Prematurity Day. The theme for the year is skin to skin from the moment of birth. The World Health Organization just launched new guidelines to have skin to skin from the moment of birth. And when you brought that idea for kangaroo care in such a setting, was there a resistance? We already had so much evidence, and there's more and more evidence always coming out. You mentioned about, stable baby and not stable babies doing skin to skin. So what did you face when you're trying to implement kangaroo care?
There was a lot of resistance. Historically, people in the area had been taught to be very careful because babies will die of hypothermia, which is true. And so their strategy was to wrap babies up in 10 layers of clothing and blankets. And so the idea of stripping a baby naked to put the baby on your chest was actually quite frightening for them, I think, initially. And what would classically happen is we'd put the baby on skin to skin, wrap mom up, walk out of the room, come back half an hour later, and baby would not be there. Baby would be bundled up somewhere else. And so one of the strategies is we actually got wraps, like a baby carrier wrap. We had some community groups that sewed them for us, just plain material. There's nothing fancy, but we would essentially tie the baby onto the mom's chest, because then they couldn't get the baby off, which again, perhaps not the best long-term solution, but it helped reinforce this is actually a really big deal. This is actually really important. Lots of education again. And then again, once the nurses and the midwives started seeing the difference, they started to encourage and promote it on their own. And it really took that buy-in from the midwives and the nurses before we started seeing better success rates.
So were you doing skin to skin or kangaroo care from the time of birth? Because you start bringing two hats into this equation, right? You had your OB hat, and now you have the neonatologist hat. So how did you manage that, and how did you implement the changes?
So one of the challenges in arriving in Angola was that there were so many areas for improvement. You got to choose your battles. And so that was one of the steps that we worked through, is what are we going to focus on first? Because you will overwhelm people if you try to change everything at once. So initially, no, we were not doing skin to skin at birth. We were focusing on other things like managing labor and promoting positive pressure ventilation and or CPAP for babies that needed some help at birth with respiratory distress. And then we brought kangaroo care in and skin to skin care later on. So I do think it's important to recognize that you're not going to fix everything instantaneously. And if you try to do that, it's not going to go over well. You got to choose your battles and work with where people are at locally to try and bring about some of those changes.
So the team, the healthcare professional you trained, are they the ones educating the parents? Because there's a lot of education also for the parents, right? I mean, we see in Canada how much education we need to understand the benefits of breastfeeding, breast milk, and kangaroo care, because we come into the ICU, we know nothing about it, right? Or how is that education transferred to parents?
You're right. It was coming from both midwives, nurses, and myself. So all three of us were involved in that. Initially, it was just me because it took a while to get some buy-in from the midwives and nurses. And then buy-in from the midwives and nurses was improving. And so they were taking over more of that role of continuing and encouraging and promoting it along the way. But that did take time.
So from one setting, how do you multiply and scale this up to a whole country to change practice in the country, to change those statistics? Because it's pretty heartbreaking to see numbers in each country of number of deaths and right for us, especially I think coming from a country like Canada, this is unthinkable for us.
Yeah.
Right? So how do you scale that up?
I think there's there's more than that, but there's kind of two approaches that I focused on and found helpful. And one of them was networking with healthcare providers in the area. I was able to speak at a local conference of pediatricians from around the country about kangaroo care and bubble CPAP and a few other things. And then the second component was word of mouth, because there's poor communication, there's poor roads, there's a lot of very rural and remote areas in many low and middle income countries. And the reality is they're not going to hear evidence-based stuff necessarily when they're out in the bush, but it's word of mouth. They're going to hear about so-and-so who had a niece, who had a daughter, who survived, and they tried this thing. And that was a big deal in Angola. There was a lot of word of mouth. That's what I'm trying to say, where people were talking about good things that were happening. And that was how information was getting out in the rural areas compared to the cities where there was more healthcare access. So it was both, I think, really, that was important.
Wow, that is incredible. So we talk about preterm birth. How early are those babies surviving?
The Kijabi Hospital in Kenya that I mentioned earlier has some of the best survival rates, down to 28 weeks gestational age. Oh. We weren't seeing as good statistics in our area, but again, I'm one OBGYN trying to do neonatology, and they have an entire pediatrics team with pediatric trained nurses. So they had more resources, I guess you could say, than we did, but they are managing down to 28 weeks gestational age.
Oh, that is incredible. We have a comment here from Selena. Selena runs the parent organization in Ghana. She said, I agree very much on the word of mouth advocacy. And Selena does an incredible work in Ghana. Every time I meet her in person, we meet once a year. It's amazing. And it really put us into perspective, right? Put our care here in Canada into perspective and see how fortunate we are. We still obviously have a lot of work to do, but we can really compare. And then she made one more comment: word of mouth helps to make sense of the scientific advocacy and brings it to life. Selena, thank you so much for joining us here today and the amazing work she does in her country. But Dr. Hudgins, one more question. So from all your learnings from these 5 areas that you focused on, that you find some simple, so let's say called simple solutions for a big impact, how can you or your group, the group that you work with, spread this across many other countries who have, like in low setting income countries? Because that's where you're going to make a huge impact, not only in a few countries, but worldwide, where the work needs to be done.
I think a lot of it has come back. Well, I think there's different components. Some of the people that I worked with were big involved in research, like Tina Slusher working out of the University of Michigan in various hospitals, and having actual evidence-based research is bringing some of this information to the forefront in academic circles. And then I think word of mouth is still a really big component. When I went back to the neonatal unit to ask, how do we do this? The neonatal unit that I was working in Saskatchewan essentially said, we don't know, but you're welcome to come and we will put you in contact. Somebody out there surely knows somebody. And so a lot of it was word of mouth. I think we need more of that. Another component is some of the language barriers. So that's partly why we did the fundraising, to try to get programs like Helping Babies Breathe translated into Portuguese, which makes it accessible to a few more countries. The fact that the American Academy of Pediatrics has free downloadable resources for some of those courses, fantastic option again for some of these low resource settings. So I think there's quite a few different ways that word can get out there, and I think all of them are necessary. The more the merrier.
Absolutely. There's one more comment here from Tanya. I just heard another presentation on immediate kangaroo care, and it was so inspired. Thank you for sharing your work. Dr. Hudgins, what is next for you? Because now you feel like you opened the doors to make this massive impact, and you're back in Canada. So what are you working on? What are your plans? Because I feel like we have a lot of dissemination of your work to be done.
I actually just literally this month came out in publication a chapter in a textbook focusing on maternal healthcare in the developing world, and have started communication with a couple of universities about doing some more teaching for their doctors in Canada about essentially how do you bring evidence-based medicine down to the reality of a low resource setting. My focus lately has been more on the maternal healthcare end of things. So I'm not quite sure. Now that that's out and published, I'm kind of looking to see what teaching opportunities might be out there. I really do have a heart for teaching. I love spreading useful information, I guess you could say. So that's a work in progress, but that's kind of where I'm at now.
Wow, that is amazing. Dr. Hudgins, thank you so much for joining us here today. I do want to bring you back because it was so nice talking to you, learning from you. And I'm hoping we can spread your work around the world, because we have many people from many other countries watching our live sessions. And we wish you all the best. And thank you so much for all the work that you've done.
You're very welcome. Thanks again for having me.
Thank you. And to all of you watching us live today, thank you so much for joining us here today. And the video of today's session and all the other videos from our live series are available on our website, which is right here, the canadianpreemies.org. Let me just bring here to the screen if I can. Here you go. And I want to thank our sponsors, AstraZeneca and Medela, for the ongoing support of our education sessions. And we are a charitable organization, and we believe that through support and education, we can empower families, ensuring they are ready to care for their babies. Please visit our website and consider making a donation. Together, we can create a brighter future for all our families. And I'll see you again next Friday, 1 p.m. Eastern Time. Stay well.